Okay, so can you please sit down? Now, based what you heard so far, I want one of you to try to define evidence-based medicine. Anybody? Please use the microphone. تفضلي. Yes. Use the, yeah. Yes, okay, that's fine, try. Yes, evidence-based medicine.
It's a clinical practice based on proven evidence or proven literature or...
I like her sentence. Why do I like her sentence? Because, yes, it's a clinical practice. She started with, it's not only knowing what the literature is, it's a clinical practice that depends on the evidence. So it's a philosophy of medical practice, like exactly what she said, based on knowledge and understanding of the medical literature, supporting each clinical decision. So it starts from the bedside. If I ask you what are the important skills that people should have to practice evidence-based medicine, what are the important skills? There are 4 important skills. Can you name them? Good. So the first part is realizing you encounter a medical problem, how can you formulate it into a clinically searchable question? Do you feel at the end you are familiar with this concept after what you had this? So you know which is the population, intervention, comparison, and outcome. What's the second skill? Where to search. Good. And this part of the session is where how to search, what are the search skills, where you get the informations, does that thing. And the third component is? Appraise. You had a lot of exercises in this, knowing the strengths and weaknesses of any trial. There is no trial is bad and trials, but there are strengths and weaknesses and you have to realize. And the fourth part is? Application. So what? Does it actually make a difference? What's the important lesson from the systematic review you had this morning? What was can somebody tell me what was the most important message in terms of application? Please use the microphone. There is one microphone here. Who wants to talk here? Where microphone, Eleni?
Doesn't matter about the result of the systematic review.
Okay, so how you apply it, and what was the? I think you were in my group, right? What was our conclusion?
It's helpful to get antibiotic, but clinically there's no big difference between 11 and 3, let's say, microphone. There's no sort of justification to use antibiotic, even there is a good solid evidence of giving antibiotic.
Do people agree with this? I want you to participate. Do people agree with this? Based on the systematic review? Huh?
We couldn't hear him well.
You couldn't hear him well. Well, he said that the results are significant, the difference, but it's not justified to change clinical practice or to actually give antibiotics as a prophylactic treatment in that case. Do you agree with this assessment? Yes? Okay. Does anybody don't agree?
I think there was insufficient data to support.
وين هذا البوي؟ فهد ما له كاميرا البوي بس كان موجود. Yes. وين الأذر مايكروفونز؟ في واحد مني؟ في واحد هني؟ Yes.
I think there was insufficient data to support the use of antibiotic. For example, the side effects of the antibiotics were not mentioned. So it could be that the side effects are more significant than prevention of a local infection.
Okay. But remember that systematic review showed 70% reduction in incidence of tooth infection. Remember? It was, but when you say 70% reduction, this is not good enough to make you actually do the intervention?
What are the side effects?
Okay, let's say the side effects was actually mainly mild and transient. It wasn't big side effects.
This is not the only factor, the reduction of risk. This is not the only factor I use in practice.
Okay, I'm trying to tell you now the application. What is the other factors?
I was trying to say, I think that statistical significance does not necessarily mean clinical significance.
Yes. Okay, statistical significance doesn't mean. Can you go further?
Like, does this work? Yeah.
Yeah.
So the numbers were statistically significant, but when you looked at it from a different perspective, from the number needed to treat,
Okay.
we saw that it was not enough.
What was
to
it? Do people
recommend-
remember?
It was
12.
Yeah.
It was 12. So that's not good enough. You 12 patients.
But then when we went with the adverse effects was 20, and then
Okay.
when we calculate the confidence intervals for each of those, it was very wide for the adverse effects.
And the clinical application here, you are treating 11 patients unnecessarily with antibiotics. The other strategies, if that patient developed tooth infection, you could treat him. So this is now the application. You take a result which shows you very positive effect. It cannot get any better. 70% reduction. But remember, 70% from an incidence of 8.3%. So if you don't give antibiotic, the incidence of tooth infection was 8.3%. So this is where you use your application skills, okay? Now, I think you did very well here, so that's okay. Do you know how did it start? Maybe I'll skip this. I just want to let you, I think Dr. Oreo did allude, here he comes. Did he allude how did it start? And it's important for you. It started, I remember when I was trainee in 1988, I'm giving you my age anyway, but anyway, there was a journal club by the Kuwait Board Internal Medicine, and this journal club included 6 or 7 questions in appraising any literature. And this question was why the study was done, who are the patient, how the study was done, methods, what was the result, and then so what? This is the result. So these were a page. Who invented this scheme? Yeah, it's a McMaster group. So this was the sort of initial stones. And this is, as you said, it was by David Sackett, who actually, Dr. Ori already told you, he's a clinical epidemiologist. And then Gordon Guyatt came and became director of internal medicine. And he carried this further, so bringing the critical appraisal to the bedside. Okay, so this was how this things developed. So I'm just giving you actually a part of the quotations from information package to residents in McMaster. Residents should develop the attitude of enlightened skepticism. Somebody mentioned in our discussion earlier today that steroid can be used for acute pericarditis, used by some physicians. So the first thing when you see this, what is the evidence of this, and is it, so whenever you see that enlightened in the application of diagnostic, therapeutic, and prognostic technology in the very management of patients. This approach has been called evidence-based medicine. It's based on principles of clinical epidemiology. And the goal is to be aware of the evidence on which one's practice is based, the soundness of this evidence, and the strength of the inference you make, which means the application. The result, does it apply to my patient, and what are the consequences? So, and this is the type of question: therapy, harm, diagnosis, prognosis. I think you already are well aware of this. Now, we ask, can you categorize the question? What kind of questions can be asked? There is actually two different kinds of questions that any sort of professions ask, or especially in medicine. Maybe I'll give you background questions and foreground questions. What's the difference between a background questions and a foreground question? Yes.
The background question is the basic knowledge, which we have in the textbook, which like basic science, pathophysiology, and so on, which is the standard knowledge.
So give me an example,
For example,
clinical example.
For example, the risk factors for atherosclerosis.
Okay, so that's good enough. So these are the kind of medical students ask the question, the etiology of, say, Crohn's disease or the etiology of exacerbations of asthma, whatever. So this is a kind, and you give the answers for usually textbooks. And the foreground questions?
Is what's new, what's in the literature, that's postgraduate level, what has been added to our knowledge of this pre-existing conditions.
Is that true? Does everybody agree? The foreground question is what's new? I want to, huh? I want people to use a microphone so everybody hears them. Maybe that group, does everybody agree? Does anybody have anything else about foreground questions? No? A foreground question is more sort of specific. You want an answer. What is the effect of statin on mortality post myocardial infarction? This is kind of a foreground questions, if you like. So it's a more specific answer. So this is most of the questions we ask in evidence-based should be a foreground questions. Okay, this is one way of looking. I have a patient with high blood pressure. What's the optimal treatment for her? It's of course it doesn't have to be very specific, as I said, but you want specific things you try to answer. Okay. Is diuretic or ACE inhibitor better first-line therapy in hypertension? So I think we're not going to do this exercise because you have done this a lot. Think of a real-life type questions. Actually, we want to do one person give me a brilliant idea to search. Can somebody had across any kind of question they had within the last 1 month or 2 weeks, and they want to search? Come on, you must have some. Yes. أنت ما تحتاج ميكروفون على صوتك.
I have a problem with one of my patients. I have a question about them. Whether we can use linezolid for amyloid bacteremia or not.
We can use.
The standard of care by guidelines is to give vancomycin.
Okay.
But linezolid has never been tried for amyloid bacteremia patients as far as I know. So can we use it?
Good. So quick. What's the population to answer this question? MRSA positive patients. MRSA positive bacteremia patients. Is that good enough? Yes. What's the intervention? Linezolid. What's the comparison? Or other standard therapy. And the outcome? How do you define a cure? So outcome here can be several. One of is mortality, one of them resolution of bacteremia at certain point. It could be from discharge and relapse. So the outcome here, it depends on what you're looking at. But of course, eradication of the bacteremia or at certain time point or mortality, which is important outcomes. Okay, good. So what are you going to look up for this answer? PubMed. You can go look up, down, or straight, but you have to look up somewhere. And PubMed is a good way to answer. Huh? There was no answer. Okay. So you can go here now. Important things is, actually, Dr. Ari already told you there is ways of looking at this. He gave the example of pre-cooked fish. Some people enjoy cooking. And actually, when you cook and you know how to cooking, you may enjoy the meal better. But also, when he used that example of pre-cooked fish, what did he mean? I'm trying to make you remember things. What did he mean in terms of the literature that we search? Pre-appraised. Okay, so that's a good thing. So there are some sources that give you pre-appraised evidence, which is helpful, but also having the skills to be able to appraise the literature increases your level, because then even if you read pre-appraised, it makes more sense to you, okay? And you can do primary databases or pre-appraised, and we're gonna actually show you, I'm trying to show you examples of these and what are the strengths of each one. So we will come to it. You can ask, a lot of things is asking a colleague's textbook, and I'm glad this year we're doing, actually, you find the exercises to do in midline searches, you found them very useful, and there's an important still how you can combine search. All of you now should know what's clinical query and how to use it, which is important. And we're gonna talk about these evidence-based tools, which are BMJ best practice, ACB Journal Club. Dr. Ario did mention ACB Journal Club. Do you all know what is ACB Journal Club by now? Or not yet? Do you all know?
Collection of, they appraise the new articles that come out, and they provide like
Okay.
a summary of it.
I'll show you example of this because it's actually very useful resource. And what is Access? What is Access? Well, Access actually with the 4 S's.
It's an abbreviation. Abbreviation.
Yes, it's an abbreviation, but it's a the brand name for what? It's a search done by who? Okay, so it's a federated search done actually by Dr. Orios and his people, and we'll show you examples what is the usefulness of this and what kind of information you can get, and it's free to register in it and get feedback. Okay. This is actually an old table here, and already Cochrane, we will talk about it. And remember, actually the ACB Journal Club, which belongs to the Annals of Internal Medicine, if you search it, I think it's worth subscribing to. It doesn't cost a lot of money, your individual subscription. I will tell you why. And we'll show now here. I want to just give you, does anybody know the history of Medline? Because when you have historical perspective, you might understand what's the history of Medline. Medline is PubMed is the search engine for Medline. Medline is the same thing as National Library of Medicine. Actually, it started as Index Medicus, which was a comprehensive bibliographic index of scientific journals, which started from 1879. So they tried here, and it was initiated by this guy, which was head of the library of the Surgeon General Office, United States. And the library later evolved into the United States National Library of Medicine. And since 1960s, it began computerizing it, it became Medlard, and then became Medline, which was the online version. Okay? So that's the historical perspective of the Medline search, or the PubMed, which is a search engine, and the time coverage from 1946 to the present. And there's about 5,600 journals with 40 languages, 22 million citations, and there's 2,000 to 4,000 added each year. So Medline is a big ocean, if you like. And to be able to search this, it's a plus. And there is Medline Plus, which is patient and consumer database, which is sometimes actually useful to look at Medline Plus because information for the patient and consumers. I think they don't need that. Now Cochrane, we will come to it. First of all, actually, before let me see, yes. So the ACB Journal Club, it's actually done by also a group of McMaster in collaboration with American College of Physicians and with the Annals of Internal Medicine. Dr. Ori told you they choose 10 articles, they pre-appraise and publish every month. Okay, if you say, and you can buy subscription. What you will get if you do that? What's the value? You will get on your email each month 10 articles like this, For example, this is one of his, and it doesn't apply only to medicine. There are surgical fields, ENT, whatever. Cohort study in patients having colonoscopy, risk associated with use of anesthesia service was compared with colonoscopy without anesthesia. How many anesthesia residents here? Do we have anesthesia resident? I'm sure we do, huh? يمكن ما في? They did not have, okay. If there is, yeah, I just want to show you here, for example, so I'm just trying to, placebo-controlled in-house dust mite allergy-related asthma, addition of sublingual allergen immunotherapy, reduced time to asthma exacerbation. This is an original article. And then you can see, I want to give you another example of what do you get now? So you appreciate the value of this. You get a one-page summary of the article, whether it's a systematic review or whatever. And this one-page summary, it goes like this. I chose one of this to give you an example. This was actually published in 2007, early treatment with prednisone or acyclovir and Bell's palsy. Who's the neurology or internal medicine residents? What is the approach for patients with Bell's palsy nowadays? What's the standard therapy? Acute Bell's, which is seventh nerve palsy, what's the standard therapy? Prednisone. Everybody gets prednisone? Huh? If they present early, they are given prednisone. Acyclovir is no longer used. Okay. So at one point, this was an issue, and you wanna try to find out. I'll tell you, this is maybe an older example, but the question is, in patient with Bell's palsy, this is in the summary. This is the one-page summary. So it's a good article. In patient with Bell's palsy, does early treatment with prednisone or acyclovir improve the chance of complete recovery of facial nerve function? Do you relate to this question? It's different when you read the original article. It's not stated that way, but people who are experienced, so this is a specific question you're trying to answer. It says this is the method, the design was 2x2 factorial. This is randomized placebo-controlled trial. So the summary of the method. The allocation was concealed. It was blinded. Clinician, patient, data collectors, and outcome assessors. So it tells you what the blinding is. And the follow-up period was up to 9 months, and the setting 17 hospitals in Scotland, United Kingdom. In that one page, it summarized the result to you. It tells you follow-up 3 months, follow-up at 9 months, prednisone versus no prednisone, acyclovir versus no acyclovir. It gives you the benefit or if there's any risk reduction, and it gives you number needed to treat. So you know there is about 27% risk reduction if you give prednisone versus no prednisone. And at 9 months, this risk reduction is less. And here you need, so when you advise your patient, when they come with Bell's palsy, you tell them, if I don't give you anything, probably at 9 months, 80% don't have any things. If I give prednisone, this 82% goes to 94%. Now we have patient preference or things that you make you decide, but at least give you the facts regarding the trial. So I find for you, I find it very useful. I encourage you really to invest the money and get these pre-appraised, because and then it helps you when you are actually appraising the articles. I'm not going to talk a lot about BMJ best practice, but it's actually some kind of a textbook. Also, you can subscribe to it. It gives you diagnosis, it gives you treatment, and also there is great evidence. So some of you might want to try this. I'm not going to spend a lot of time on it. But I want to tell something about Cochrane. Who's Cochrane? Does anybody know?
He's the guy who funded Cochrane.
Is he the guy who found Cochrane? He's a from very materialistic. Yeah, anybody who finds it, you give the name. He's not a physician? Actually, you might be mixing up with somebody else. Does anybody know who is Cochrane? No? Actually, he's not the guy who found Cochrane. He's a Scottish physician. He's called Archibald Cochrane. He was born in 1909 and died in 1988. Actually, the Cochrane collaboration started in 1994, after his death. And they named it after him for some reasons. He is actually an advocate that any intervention should always be tested in a randomized controlled trial. And he was putting this idea. And I'll show you one example of his work to illustrate the importance of randomized controlled trial. He wrote a book called Effectiveness and Efficiency, Random Reflection on Health. You can download this as a PDF. If you want to buy the book, which is available on Amazon, I think the cost is several $1,000s if you want to buy the original book, which is an antique now, but you can download it. What he said, he made a randomized controlled trial while he was captured as a soldier in World War II. He was captured by the German in Salonika, which is somewhere in Greek, and he wasn't, because he's a physician, there's many patients with lower limb edema, okay? And he thought this lower limb edema was because of a peri-peri. What's peri-peri? He thought this was a deficiency of vitamin B. So what he said, he wanted ask the German, but that he decided to do a study because he thought this was vitamin D deficiency. What he did, he cleared 2 wards and they numbered the 20 prisoners of odd numbers to one ward and even numbers to the others. Is this randomization? It's not good randomization, but at least it's some kind of randomization, okay? Each man in one ward received 2 spoonfuls of yeast daily. The other got 1 tablet of vitamin C. Is this a controlled trial? Yeah, it is a controlled in a way. So he believed that yeast will cure this problem, but he wanted to do it a control. How did he assess the outcome? This was done while he is in captivity. How did he assess the outcome? Okay, how would he assess the outcome? How do you decrease the edema? You measure urine output, correct? But they did not have buckets to measure urine output. He thought about this. So I asked my helping staff to measure the frequency of urination between the 2 groups. We had no buckets. There was no difference between the wards. And also I asked members of the ward whether they felt better, the same, or worse. So there was subjective improvement by the patient. 9 out of 10 in the yeast ward felt better, none in the others. And in the 4th day, there were people who had yeast. They were going to the toilet more often. And also, I also made them walk about half an hour, and then assess the extent of the edema. So it's more subjective, but I convinced myself that there was less edema in the yeast ward. Then they presented the result of my trial and argued with a major epidemic due to a diet deficient in vitamin B. And actually, he wrote this notes, he documented, and he published it later on in 1984, which shows the incidence of edema. So he said this was one of the sickness in Salonika, my first, worst, and most successful trial. This is what's first. The reason it is worse, because it was not a good trial. I was testing the wrong hypothesis. The edema was not wet peri-peri. The number was too small, time was too short, outcome measurement was poor, yet the treatment worked. I still don't know why. Maybe it's simply that small amount of protein in the yeast raised the plasma protein sufficiently to correct. I wanted to show you some historical perspective. So when you go to Cochrane, you know who's Cochrane and what he did. And now Cochrane is a non-profit organization. It's based in London and it's based on volunteers. All these Cochrane reviews are actually volunteer, and they do, which you had an example, and to organize medical research information in a systematic way based on evidence-based medicine. And you've seen how extensive they do the research, how they present their results, and it's the, if you like, the mecca of systematic reviews, okay? So whenever you are looking for systematic reviews, go to your Cochrane and try to get familiar with it. Now, who performed the first clinical trial in history? Wasn't Cochrane. Do you know who performed the first clinical? Yes, you're right. What did he do? What was the disease? Not rickets, it's scurvy, yes. Scurvy. And do you know the number of patients? I think it was 6 or 8. And the hypothesis, it was actually Lind. And he's also Scottish in 1747, and he had 6. He divided the 12 patients into 6 groups, and he gave each. One of them was oranges, and one is lemons, and the treatment of group 5 here stopped after 6 days when they ran out of fruit. By the time one sailor was fit for duty, while the others had almost recovered, but all the others actually did not improve. So he was first evident that citrus fruit treatment for scurvy, which because of vitamin C. Now we come to access. You know that and I told you, all of you should really register for it. And this is, they mark it into stars, and the S's here, for example, study, synthesis. When you do the 6S pyramids, start from non-appraised to studies, which is original articles, and then synopsis of the studies, synthesis. So all the systematic review and all this comes here. And I think Dr. Ori already told you, computerized decision support, it's not available yet, or maybe there is, it's infancy, but eventually it might come to a computerized decision support. This is the website, but if you do access, it's a plus.mcmaster.ca, and you only have to register. You can see my name and password here, and you can do, you will get an email alert. You choose the articles that you get. And this is actually, okay, this is something that I did recently. What was the major catastrophic event happened in Kuwait medically later on? Huh? Thunderstorm asthma. And many people, or actually not a lot of, it was a major, many admitted to ICU, and people unfortunately died from it. So I did last night search in the Access white thunderstorm asthma as a quick things, and I came with, it's mentioned in UpToDate, triggers to control, but the good thing here in the PubMed clinic, because what they do, you know that clinical query search that you do, it's done within the system, and they show you the results, okay? And here, the clinical query, and here PubMed, it's causing. So, and there were 3 articles here and 10 articles here. One of them, thunder-related asthma, what happens and why. Although in the search it says systematic review, but when I looked at the article, it was not actually a systematic review, but it was a review, okay? And also in these 10 trials, I'll show it to you. Thunderstorm-related asthma, what happens and why. The impact of thunderstorm asthma on emergency department attendees across London in 2013. And actually somebody asked me the other day, is there any reports in the region There was a report in Iran, an overview of thunderstorm-associated asthma outbreak in southwest of Iran. So this is to just show you an example of a search of this site and give you, and of course, there's many, if you do it on other things that you get answers. So it's a very useful site, okay? Any questions? Does anybody have any question regarding ACB Journal Club, regarding Medline, regarding Access, Cochrane? No? Everybody's happy? Okay, thank you.